As a surgeon, I trust my hands. 20 years of training compressed into an instrument. Most of us never question that ownership. The hand obeys because it is ours. But there is a condition in which that contract breaks. The hand unbuttons what the patient just buttoned. It grabs objects the patient did not mean to touch. In one case, the left hand reached for her own throat. She watched it. She could not stop it. I have been a surgeon for 20 years. This is one of the conditions I cannot explain. Let me tell you what we know. Alien hand syndrome is not new. The first rigorous description dates to 1908, when the German neurologist examined a woman with a right hemisphere stroke, whose left hand behaved as if it belonged to someone else. He published the case in the Journal für Psychologie und Neurologie. 118 years later, we are still trying to explain what he described. The term alien hand is a loose translation. The original French, coined in 1972 by Sigolin and Constantin in a paper in Revue Neurologique, was literally stranger hand, and documented 3 patients with tumors invading the thick band of fibers connecting the 2 hemispheres of the brain. In all 3, one hand behaved with apparent purpose that the patient did not own. Since then, neurologists have recognized 3 anatomical variants. Each has a different lesion location. Each has a different phenomenology. And almost certainly, each has a different mechanism. The first is the frontal variant, damage to the medial frontal cortex, especially the supplementary motor area. These patients show compulsive grasping. If an object enters the hand's visual reach, the hand takes it and tries to use it, regardless of whether the patient wants to. The second is the variant, damage to the itself, either from stroke, from tumor, or from the surgical section performed decades ago for refractory epilepsy. These patients show conflict. The 2 hands work against each other. One hand buttons, the other unbuttons. The third is the posterior variant, damage to parietal or occipital regions. The hand drifts, it gropes, it levitates, less purposeful, more alien in the looser sense. The most cited synthesis is a 2014 review by Francisco Carrasco and colleagues in Frontiers in Human Neuroscience. They argue that the 3 variants share a final common pathway, a breakdown of the mechanisms that tag a movement as self-generated, but diverge upstream in which part of that machinery has been knocked out. Prevalence numbers are soft. Alien hand syndrome is rare enough that most neurologists see fewer than a handful of cases in a career. But it has been documented continuously, across languages and continents, for more than a century. What we are looking at is not an artifact. Here is what mainstream neurology believes. The mechanism, as best we understand it, is a disconnection. Voluntary movement in the normally functioning brain is not just a command. It is accompanied by what Patrick Hsu, a cognitive neuroscientist at University College London, has called the corollary discharge. Every time the motor cortex fires to move a limb, a copy of that command is sent forward to the brain's sensory systems. The copy acts as a tag. It says, "This incoming feedback is self-generated. Ignore the surprise. Expect it." When the tagging system is disrupted, the movement still happens. The motor cortex fires, the hand moves, but the corollary discharge is gone, or it arrives at the wrong address, and the brain encounters the movement as if it had come from outside. The limb moves, and the subject watches the limb move. Functional imaging gives us a handle on this. Studies in alien hand patients have shown activation of primary motor cortex without the typical medial frontal preparation activity that precedes voluntary movement in controls. The machinery of movement fires. The machinery of authorship does not. Its 2017 review in Nature reviews neuroscience, the most cited synthesis of the agency literature, frames it this way. The sense of agency is not a metaphysical add-on. It is a constructed perception, built on the back of motor preparation signals, prediction, and a narrow temporal window of coincidence detection. Break any one of those components, and the experience of authorship fails. Now the skeptical voice, because the field does not agree on everything. Lisa and Alice Cronin-Gallam, in their 2003 review in Behavioral and Cognitive Neuroscience Reviews, argued that the term alien hand is clinically useful but neurologically imprecise. Some patients labeled with alien hand syndrome are probably better described as having motor. Others, environmental dependency syndrome, what the French neurologist Francois called utilization behavior. Still others, genuine agency dissociation. Their argument, in plain language, we may be putting 3 or 4 different conditions under one umbrella because the phenomenology feels similar from the outside. Research will advance faster, they wrote, when we stop collapsing the subtypes. That criticism is fair. It is also the reason why, when I read a new case report, I pay attention not just to what the hand does, but to where exactly the lesion is. This is where it gets harder, because the mechanism I just described explains the movement. It does not explain the awareness. In 1989, George Banks and colleagues at the University of Pittsburgh published a case in the Journal of Neurology, Neurosurgery, and Psychiatry. A woman in her 60s had an infarct in her. For the rest of her life, her left hand did not obey her. Most of the time, it was a nuisance, unbuttoning clothes she had buttoned, pulling bed sheets off, interfering with tasks. But on several occasions, the hand reached for her own throat and tried to choke her. Her right hand had to physically pry it off. She was awake. She was oriented. She could tell the examining physician, in real time, what her left hand was doing, and that she did not want it to do it. She could not stop it with anything except the other hand. 12 years later, in 2001, and colleagues at Kyoto University reported a 70-year-old woman after a stroke. Her alien left hand systematically undid the work of her right. She would button a blouse, and the left hand would fall behind, like a shadow, and unbutton. She would open a door, and the left hand would push it closed again. The behavior was goal-directed. It was not a twitch. It was not a seizure. It was coordinated counteraction. And then, in 1994 in Neuropsychologia, described a patient whose alien hand showed what they called utilization behavior. If a cigarette entered the hand's field, the hand grasped the cigarette and moved it toward the mouth. If a cup entered the hand's field, the hand reached and drank. Not because the patient wanted a drink, because the object was there. In each of these cases, the patients were cognitively intact in every other way. Memory, preserved. Language, preserved. Executive function, preserved for every task, not contaminated by the alien limb. Sensation in the affected hand, preserved. Proprioception, preserved. The patient could tell you, without hesitation, that the limb was anatomically theirs. What they could not tell you was why it moved. This is where the standard disconnection story begins to strain. If all that fails is the corollary discharge, the tag that marks a movement as self-generated, we would expect the patient to feel surprised by the movement, but not to see it as goal-directed. These hands did not just move. They executed plans the patient did not author. So the question, I think, is not whether the movement originated without agency. The question is whether the movement originated with some other agency. A motor planner operating below the threshold of conscious intention. But still competent enough to execute purposeful action. Somewhere in the brain of that patient in the bank's case, something decided to close a hand around a throat. And whatever decided was not her. She lived for several more years after the case report. She learned to keep the left hand under a soft mitten when she slept. She told the clinicians who followed her, toward the end, that she had stopped thinking of it as her hand. It was a hand. It was attached to her. Those were two different facts. The active laboratories working on this right now are a small and specific group. Patrick's lab at University College London has built the most rigorous experimental framework we have for measuring the sense of agency in healthy volunteers. Their paradigm, asking subjects to report when they intended an action and when they perceived the action occurring, and measuring the interval between those two events, has given us a quantitative handle on a subjective experience that used to be philosophy. Michael at Dartmouth has been studying patience, the split brain cohort where surgeons severed the decades ago for intractable epilepsy, for most of his career. Those patients, in controlled experiments, show milder but persistent versions of conflict. The right hemisphere, cut off from left hemisphere language, still has motor preferences. When the conditions are right, it acts on them. The patient describes the behavior in the third person. What we do not yet have is an instrument that directly visualizes the corollary discharge. We can detect motor cortex activity with at millisecond resolution. We can see the preparation activity that precedes voluntary movement. What we cannot see is the discharge itself, because we do not know where it is stored or how it propagates. Is it a single signal? A population code? A timing relationship between regions? The mechanism is still inferential. Transcranial magnetic stimulation, TMS, over the intact hemisphere has been tried experimentally as a way of modulating the symptoms. The results are preliminary. Some patients report transient improvement. No one has replicated it in a properly controlled trial. And the deepest open question, the one neither the imaging labs nor the bedside clinicians can answer yet, is why some patients habituate and integrate the alien limb over months, while others remain persistently troubled by it for years. The lesions look comparable. The mechanisms appear similar. But the subjective trajectory diverges. Something about the rest of the brain, the untouched cortex, perhaps, or prior personality, or social scaffolding, determines whether the patient learns to live with the hand or lives against it forever. This is the channel I come back to. Consciousness, the sense of owning a movement, of being the author of one's own body, is not currently a vital sign. We measure pulse, blood pressure, respiration, temperature. We do not measure the signal that makes a moving hand feel like yours. Alien hand syndrome is one of the places where that unmeasured signal fails, and the failure is visible. I think it is the fifth vital we have not yet learned how to instrument. I want to come back to the patient in the bank's case. She is not real to me in the way my own patients are real. I did not operate on her. I did not round on her. I read her case in a journal years after her death. And yet the image of her right hand prying her left hand off her own throat. It follows me. There are things medicine is good at. We are good at correcting the mechanical. We are good at restoring physiology. We are good at reattaching a hand to a body after trauma. We are not good at restoring ownership. If the fibers are gone, they are gone. We can teach the patient to keep the hand occupied. We can prescribe a soft mitten. We can position the hand behind the back during tasks. What we cannot do is re-engineer the moment between motor command and sensory expectation that makes the movement feel like hers. That is not a failure of effort. It is a failure of our instruments. We have not yet built the tool that would let us see, directly, the signal we would need to repair. I think about her, and I think about the patients I have seen come out of long operations slightly different from how they went in. I do not know exactly what was displaced. I do not know what tells any of us that the hand at the end of our own arm is ours. But I know that signal exists. And I know, so far, that when it is taken, we have no way to give it back.